My next speaker is someone who doesn't need any introduction in this community. He's a leading breast cancer researcher. And he asked a very simple question. Of some of the drugs that we use in the treatment of breast cancer, could there be a difference on the basis of people's ethnicity in terms of maybe toxicities, maybe how people tolerate those drugs? And you will find your answer very shortly. So with great pleasure, I would like to introduce Dr. Bryan Schneider, who's a professor of oncology and pathology at IU Medical School. And he will be talking to us about treating breast cancer patients and how ethnicity and race matters. Professor Schneider.
All right. Well, thank you, Dr. Vera. It's a delight to be here this morning and really an esteemed group today. So this will be a real honor for me. And as Dr. Vera mentioned, I'm going to talk a little bit today about how diversity matters in trials, but really thinking about a very focused approach to overcome a specific disparity. So if you've read the literature recently in the last 5 or 6 years, you see a million publications looking at associations between race and outcomes. My area of interest, as mentioned, is breast cancer disparities. And I think the things you see here have been replicated over and over, and I think we can establish our fact. We know that Black patients with breast cancer have increased mortality, a younger age at diagnosis, higher stage, differences in preventive measures, differences in treatment, differences in tumor biology. I've listed here increased risk of triple-negative breast cancer, but we've really gone beyond that now with some fundamental differences in intrinsic subtyping and some really elegant work looking at the molecular level. So Dr. Melissa Davis and her group have done just some astonishing work in the last few years. I won't have time to drill into this today, but really fun stuff. Increased drug toxicity as well. Now, what I think is important as we think about each of these outcomes, they are really a function of a multitude of attributes. They include differences in tumor and host genomics, differences in biology, access to care, social determinants, implicit biases, racism, and I think equally important, these are all intertwined, and I'm going to try to show you an example of how they are intimately intertwined. And I think also as we iteratively think about trying to do away with disparities, we have to understand the relative attribution of each of these so we can really build effective measures and hit those attributes that are most important for the given outcome. So I'm going to focus today on increased risk of drug-induced toxicity. And stepping back a little bit, many of my patients come and say they are more fearful of the word chemotherapy than they are the word cancer. And the reason for that, of course, is the devastating side effects that many of our therapies employ. And as a medical oncologist, I think sometimes I get a bit flippant, not recognizing that the drugs I'm using every day are at a very narrow margin of mortality and certainly high morbidity. And so these are things that I think become very important in a patient's journey through cancer. So our group really set out to see, could we predict those patients who might be at a higher risk of getting a side effect before they're ever exposed to the drug? And one of those ways we thought about was looking at our own inherited genetic variation to see if we could predict who are going to be set up for side effects. So we were fortunate in that we received funding long ago now to look at the inherited genetic variability within a large ECOG cooperative group adjuvant breast cancer trial. This trial was called E50-103. E50-103 randomized about 5,000 patients to a standard backbone of chemotherapy. So everybody got 4 cycles of doxorubicin-based therapy, followed by weekly paclitaxel, with a randomization to bevacizumab or not. And you'll remember that was, of course, a negative trial and that bevacizumab didn't benefit patients. But when we were looking at the genetic makeup, one thing was astonishing. African ancestry was almost always associated with an increased risk of toxicity, whether we're looking at BEV-induced hypertension, anthracycline-induced congestive heart failure, and what I'll focus a bit on today, which is taxane-induced peripheral neuropathy. And so what you see here is an increased risk almost a doubling compared to patients of European ancestry. And to remind you, grade 2 neuropathy is difficulty with activities. Grade 3 neuropathy is difficulty with activities of daily living. That's brushing your teeth. And you can see here, not an inconsequential proportion of the population had this. Now, we also wanted to look at the intersection of toxicity with survival. Now, with some of our biological drugs, we actually early on found that if you have a side effect, you may actually do a bit better, so the no pain, no gain phenomenon. But here's what we found with neuropathy. So clearly, patients of African ancestry have more dose reductions due to neuropathy. But what we wanted to see is how the dose reductions impacted disease-free survival. The blue and gold lines on this Kaplan-Meier curve from E5103 represent patients of European ancestry who did and did not have dose modifications, so it doesn't matter. If you look at the patients of African ancestry, however, the black line represents those patients who did not have a dose reduction. The survival is identical to the patients of European ancestry. However, those who did have a dose reduction, here is where you see a massively and statistically significantly inferior cure rate. So here, the toxicity not only impacts quality of life, it impacts the likelihood of being cured of your breast cancer. Now, we also recognize that not all patients of African ancestry got neuropathy, so we also identified some genetic variants that predicted those patients who would be at higher risk of getting neuropathy and maybe those at a bit lower risk. Now, in addition to race and genetics, we know the type of taxane one uses can also have implications with the risk of neuropathy. So this is from the old trial E1199. This was another 5,000 patient adjuvant trial. Everybody got 4 cycles of AC, followed by either paclitaxel or docetaxel, given either weekly or every 3 weeks. Now, this is unpublished data, but we went back and looked at rates of neuropathy, and you can see for the white population, slightly more neuropathy for weekly paclitaxel, but for the black population, markedly more neuropathy for weekly paclitaxel. And in fact, when you look at this 4-arm trial, the every 3-week docetaxel arm is the only arm where there were fewer toxicity and fewer dose reductions for the black population compared to the white population. So this led to this trial. This is EAZ 171. This is an NCI cooperative group study. This trial was specifically for patients who were self-defined as African American or of black race and who were planning to receive a taxane in the curative setting for breast cancer. This was a non-randomized pragmatic study, so patients here received either weekly paclitaxel or every 3-week docetaxel. Our primary objective was to see if we could validate germline predictors to predict who gets neuropathy with 2 key secondary objectives. The first of which was to compare the rates of neuropathy between the 2 arms, and then also the likelihood of dose reduction between the 2 arms. So this trial, of course, was the first NCI cooperative group study to ever focus accrual entirely on black patients with the goal of overcoming a disparity. So there were some hurdles at the beginning. Many were fearful because this is a population underrepresented in clinical trials. It would be hard to accrue. And this was a non-intervention trial in the midst of a global pandemic. So we were very fortunate to collaborate with some amazing patient advocates. This is a snapshot here of a video talking about neuropathy from Lisa Hayes and Nadia Miller. They run Pink Forever Ending Disparities here in the Indianapolis area, an amazing foundation to try to overcome disparities for breast cancer. And really, they worked with us from the beginning in thinking about the inception of this trial. They helped us build educational material, helped us with recruitment, and not just recruitment here in the Indy area, but across the entire United States where this trial was being conducted. And then when our conclusions came in, really helped us refine them in a way that I think was thoughtful in terms of how our patients would receive it. So the trial did complete. You can see here the demographics. All the patients were self-described as black. One patient described herself as multiracial. You can see here the BMI, about a quarter of the population had a BMI of less than 30. The hemoglobin A1C, 20 to 30% had a hemoglobin A1C greater than 6.5 at baseline. About 20 to 25% had an annual income less than $20,000, but almost everybody did have health insurance. Here in this trial, we did confirm a very high rate of neuropathy in this population at about 35%. The major covariate that was significantly associated with risk of neuropathy was an elevated BMI. Now, this was a look at our genetic predictor, and so here we had comparison of the high-risk genetics versus low risk. Our preliminary data suggested that the high-risk population would have a rate of neuropathy at about 38%. So we hit this pretty well. Unfortunately, the low-risk population had a higher rate of neuropathy than our preliminary data would have suggested. So although we did find a 12% absolute difference in neuropathy, in this relatively small trial, we did not have statistical significance to validate. What we did find, though, is that patients had a markedly higher rate of grade 2 neuropathy for paclitaxel and grade 3 neuropathy. We also, though, wanted to look at this from the patient perspective. We know that patient-reported outcomes are more sensitive. So here you see strikingly similar data with more moderate and severe neuropathy for paclitaxel. As I mentioned before, dose reductions are impactful here and may have implications with survival. So if you look at dose reductions due to neuropathy, they were higher in the paclitaxel arm. But we know with every drug there are trade-offs and side effects, so we wanted to look at dose reductions regardless of attribution. And here you can see still higher in the paclitaxel arm. So our conclusions were that there were numerically higher rates of neuropathy in our high-risk genotype, but this did not reach statistical significance, and that every 3-week dose of Taxol was associated with less grade 2 and above neuropathy, less dose reductions compared to weekly paclitaxel, and thus every 3-week dose of Taxol may be a better taxane option in Black patients where neuropathy is more common, severe, and can impact disease outcomes. We also felt this was true. Tailoring research to the needs of underserved population can be effective in clinical trials. And I firmly believe this trial did succeed because of our partnership with the patients it was meant to serve. So I was very excited. So these are the NCCN guidelines. This is just updated from January and published in February. And you can see now that this has been included as a formal recommendation with the NCCN guidelines. So here, patients at risk of taxane-induced neuropathy, such as African descent, may consider docetaxel as a preferred taxane based on data supporting less TIPN and less dose reductions. And my understanding is this may be one of the few, if not only, race-specific recommendations within the NCCN guidelines to date. So in conclusion, disparities obviously still exist across multiple endpoints, and hopefully, as I've shown you, they are multifactorial but heavily intertwined. And importantly, the attribution is going to vary, whether we're looking at neuropathy, another side effect, outcomes, disease type. And so really understanding the relative attribution, I think, is going to be key in our goals of trying to eliminate disparities. But I do think, ultimately, focused approaches and attention will nullify disparities by improving access, improving representation in our genomic databases, increasing accrual to trials with planned subset analyses, and I know we're going to hear about that a little bit later today, and similar to EAZ 171, designing trials to specifically address suboptimal outcomes. Now, I don't want to glance over this slide. This is very important to me. I first want to thank the patients who participated. You got to remember, these are patients who participated in a clinical trial where we explicitly told them this trial will not help you. So we're going to ask you to do extra blood draws, extra paperwork, and you are doing this to help the community at large. And it was an inspiring endeavor for me, probably the greatest of my career, to see the enthusiasm, the community based around the excitement of enrollment here. And on a similar note, of course, as I mentioned, our patient advocates have become part of my family. We collaborate, we talk all the time about strategies moving forward. We actually have, although our genetic predictors were negative, we have some really cool data that'll be coming out hopefully soon, looking at polygenic modeling and genetic and non-genomic predictors. So I think hopefully more to come. My laboratory are amazing people. They work tirelessly to give us really clean results. And I want to finish by thanking Edith Mitchell and Warda McCaskill-Stevens. So both of these investigators are, in my opinion, some of the heroes of disparities research and really took me under their wing early on in this to help the design of the trial, to help through the many, as you can imagine, hurdles of an unprecedented trial going through the NCI. And in fact, I remember speaking with Edith early on, and she said, I said, I'm worried I'm probably not the right person to lead this trial, as a middle-aged white guy. And she said, you are the exact person to lead this trial, and you will. And they did amazing work to make this come to fruition. So we ended up presenting this at the ASCO oral breast session this year, and it was one of the media worthy with a simultaneous publication in JCO. So we're very proud of that. Unfortunately, both Edith and Warda died before the presentation, so they never had the chance to see it. But I know were looking from above and smiling. So grateful to them, and want to thank you, Dr. Bira, for the chance to talk today.